So let me welcome you all and thank you for joining us today at NRTRC's monthly webinar. We've got a good program for you today, but before we start, I'd like to just go quickly through the Adobe Connect display so you know for sure what you're seeing here. You'll see it where the green arrow is pointing, a list of attendees, presenters, and hosts. That's good for your reference. Over here in the Files pod, you have an opportunity to click on the visual visits and download today's presentations in a PDF format. Below that is a web links file, which will link you out to our website and to our SurveyMonkey. And we'd like to ask our participants to tell us what you think about today's presentation, as well as give us some ideas on what you'd like to see in the future. And we will go on with that. We find that people are generally reluctant to take the survey, so Martha has found a means of getting the survey on your screen before we close out. So she'll sneak that up there on you. Also, in the Files menu, usually we have our Save the Date card. We have set the dates for our upcoming 2016 conference. It'll be in Seattle in the third weekend in March, so we invite you all to join us there. Down in the bottom, the right-hand pod is for chat. That's for discussing technical issues or asking, I don't want to say conduct questions, but questions about the procedures. To the left of that is the question and answer pod. If you have questions for Mary, you can enter them in the bottom and hit return, and they will show up, and Mary will see them, and she will answer them as timing is appropriate. And then over here all the way on the left are just some notes that basically repeat what I've just told you. I also want to invite you to our next webinar on June 25th. Our favorite star, Jonathan Neufeld, is joining us, and he's going to talk about his new telemental health video toolkit that we did in collaboration with Upper Midwest Telehealth Resource Center and Jonathan. It's a video toolkit, and they discuss everything ranging from how to set up a room for telehealth to actually how to do telemental health counseling on the internet, and including, and this really shocked me, so I'm going to make sure Jonathan talks about it, including hypnosis via telemedicine. So that's next month. So please join us. And now, that's enough of me talking. I'd like to take this opportunity to introduce our speaker. Mary Graham she didn't send me much of a bio. I know that she works with Priority Health, and she's an LMSW, which I believe is a licensed master's
in social work. Mm-hmm.
Yeah. And Mary's going to talk about the view of telehealth from a provider view, and I think you're going to find some very interesting information about what's going on back there in Michigan. So Mary, I'm going to quit talking and ask you to take it away.
Sure thing. Thank you, Bob. Thank you for joining us today. As Bob said, my name is Mary Graham, and I work at Priority Health. I've been here at the plan for 13 years, and before that I worked in mental health and in a Medicaid regional health plan. One of the things that I wanted to make sure that we do as we have this conversation today is make sure that we're all starting from the same place. We are a plan here in Michigan that has been devoted to, we pride ourselves on pushing the envelope and really being innovative. But I'm not assuming that you understand what the rules are here in Michigan or what even a health plan does. So part of the presentation is really going to be about a little bit about us, so that you understand that we are what we do as a health plan and how we look at the world, but also how we have to play by slightly different rules than other plans might be doing. So a little bit about us. And I have to, here we go. Priority Health, this is a standard advertising approach for us, is that we have a healthier approach to healthcare. We are Michigan's second largest health plan, serving more than 500,000 people here in Michigan. And we're committed to improving the health and lives of our neighbors. We serve people at every stage of their lives. We do Medicare, Medicaid, and commercial products. And we also have a network that is over 95% of the providers here in Michigan. When you saw the Michigan map, you saw both our famous mitten and the UP as well. We are not currently active in the UP. That is in our, of course, on our radar. But right now, when we talk about the 95% of Michigan providers, we're talking about the lower half, the lower peninsula of Michigan. We are a provider-owned entity, and we are not for profit, and I think that's an important aspect of who we are and how we approach healthcare, because we do approach everything with the provider in mind. When we talk to our providers, we always like to remember that we are one of many people at the table, and there's many people involved in the healthcare delivery process. It might be an agent, could be an employer. I don't know if you can see my cursor waving around here, but the employer is paying for the services, and so we have to remember their interests in this equation. If they're not, it might be the government for Medicare and Medicaid. Then, of course, there's the provider, the member, and or patient, and us as the plan. So there's many people, not all of whom are engaged in any conversation that we might be having. When we look at provider engagement, one of the things that we want to remember, of course, is that you have to conduct a business, and things that are critically important to you, these are small, so you may want to make your screen bigger for right now while we're doing the conversational part, while I'm presenting, is operations are pretty critically important to any provider. You're going to worry about claims payment, you're going to worry about enrollment and eligibility, whether the physicians themselves are credentialed and set up properly. If we can't do the basics well, then we need to concentrate on that before we get to any innovation. Administration then, how easy is it to work with us? Is our website providing the information that you need? Can you get the answers when you need them and when you're doing business with a patient standing at your desk? Do we have the information for seamless operation out there? Then we have a very robust pay-for-performance program that has been in place since 1997, built off HEDIS, and when 5-star came into play, that was added, obviously. But 10 to 15% of our primary care network is very involved and very engaged. 10 to 15% of the payment for our PCP network is pretty much tied to that program. So they're very involved in that, and we've been very successful with our incentive program. These three things are pretty foundational to how we work with our providers, and then we get to network engagement and accountable care with our large trading partners, our groups and POs, PHOs, IPAs. Those are all the organizational elements that we might be working with. We have to do all of that work well and nimbly in order to get to the network engagement strategy, which includes these 5 components. You may be familiar with the triple aim, which is pretty foundational to a lot of work going on throughout the United States around cost, outcomes, and experience to the providers. What we've done, or to the members, what we've done is taken 5 key elements that we want to use to have meaningful conversations with our networks, which is POs, PHOs. And the first one would be access to care and patient experience, because if we don't have access to care, we need to sort of full stop and start talking about that. You take Medicare and commercial, but you don't take Medicaid, we need to have a conversation. The patient experience is also a critical element, and so these are the first 2 things that we would work on with any group. If they're done and it's not an issue, then we're going to move on to the next one, which is fair and transparent pricing. If that's all in place, because if we can't price a product well in order to be competitive in the market and give a fair price to our members or our employers, then we need to have another conversation. One of the things that you may not be familiar with that's pretty important for us, and we are unique in our market, is that 50% of our commercial plans really are high deductible. So that means the member really has skin in the game and are very concerned about the pricing. In fact, we have some tools that we're doing to expose that kind of pricing to our members. Continuous quality improvement, I mentioned a little bit about an incentive program to the PCPs. We also have one for hospitals, and we also have a PT incentive program. And we're constantly working and looking at ways we can improve the outcomes and the performance for our members in the plan. Economic alignment goes to whether we have shared risk, full risk, shared premium, how we can incent and build on our relationships with those providers and those organizations to make sure that we're really all moving in the same direction, looking at the same kinds of market impact and getting the outcomes that we need. And then clinical collaboration. If we've got all these other things in place, then we can really talk about how can we do some home-based primary care? How can we expedite and facilitate transitions of care? What about case management? What about patient-centered medical home? Working with the advanced medical home? What are the opportunities that exist in clinical collaboration? And so we are, as a plan, obviously pushing the envelope, obviously having a lot of innovation in our market. I wanted to provide some examples, and you'll see virtual visits is the first one up. Not to toot our horn, but this was why we were invited to present to you today. Access, it is about virtual visits. With the Affordable Care Act and Medicaid expansion, we were very concerned, and PCP shortage, we're concerned about providing access to those members and making sure that we right-size the member's visit. If they're going to a PCP and taking space in the office, then that's capacity that the physician does not have to deal with chronic care. In addition, if they're not going to their PCP and going to urgent care, retail clinics, or emergency rooms, that's not right sizing either, and that's certainly not, it's over treatment for care that we regard as pretty low complexity, high frequency, high acuity. So we wanted to provide a service, and I'm going to talk more about that for the second half of the presentation. But this would fit the first element of the network engagement strategy. The second element is about transparency, fair and transparent pricing, and it's not just about helping people shop, but it's how to engage the members. And you'll see here that we have e-visits, which is where we're migrating to with our virtual visit product. But we also have the cost estimator, and we'll talk about that as well. Somehow I jumped. I must have clicked the wrong button. There we go. Cost estimator is our transparency tool. And so when you go on as a member and click in the kind of service that you need, in this case a knee arthroscopy, you pick your physician, and then we will tell you, well, this facility will give you this price, and that would keep you in the green. And your estimated cost would be $941. The second slide that we would normally have in a slide deck that was about transparency would show that the estimated cost at ABC facility would be $2,248, so that the member would have a high differential in the cost if they went to a green versus a red facility. And that is available to our members. And it is not a guarantee of cost. That's why we call it estimator. But it's pretty darn close. Because as you and I know, when you go to the doctor, there may be complications, there may be other issues, there may be an additional procedure, but this gives them a good idea of what this particular service, if it's only this service, should cost them. Here's our continuous improvement slide, and this slide shows you 3 different things that are going on with our incentive program. Here's how we display our physicians on our Find a Doc, and by the way, you can go out to PriorityHealth.com and go into our Find a Doc tool and be able to see our doctor ratings based on their quality performance with us in the prior year for primary care. So you can see how well they're rated relative to preventive care measures, chronic care measures, and so forth. So this particular Apple rating is fueled by the incentive program, and here you'll see just a sort of side-by-side quick reference guide that we published for them on all the measures and the targets. And then we also, based on this incentive program, are able to give the really high performers quality awards. And you can see our Apple theme is repeated there. Getting close to the end of the network engagement strategy, this is our economic alignment slide. We talk about total cost of care arrangements, enhanced fee for service, outcomes-based incentive payments, which is, again, to a great extent our primary care incentive program, and then direct clinical program support, the kinds of things that we're doing in the clinical collaboration realm. And in clinical collaboration, we actually have this 6 cog wheel where we talk about care management, post-acute care transitions, senior care, medication therapy management. We're very, very engaged in working and developing these programs and collaborating with our providers' systems to pilot and introduce these into their communities. Because we want to attack chronic disease, that's where, at the end of the day, if we can prevent people at level 2 or level 3 acuity from moving up the scale to level 4 or level 5, where the real costs lie, even though these are tiny portions of our population, this will make a big difference in their lives, in their quality of lives, in our ability to deal with managing care in the community overall and long term, but also to us as a plan. So, with all this going on, why virtual visits? Well, in 2013, I was approached to lead a project that would introduce a vendor-based service into the market. That process, we were asked to engage in around February, went to RFP later that month, and we just started to learn an awful lot about what was out there in the community and what the vendors were able to offer. The reason we did it was to respond to the market, and because our networks really weren't doing this work yet. It was not even a glimmer in their eye that they might be going towards virtual visits with so much going on with meaningful use in PCMH. So what we did is we said, okay, we're going to fill the gap. We're going to respond to the market. We're going to respond. Employers are asking for this. Members are asking for this. We're worried about access. We're concerned that that the world is going mobile and we're not present in that area yet. We need to do something. Let's go ahead and look at vendors. And we were not the first ones to think of it. The one up in the upper left-hand corner, West Nudge Avenue, Meyer, that's in the community of Kalamazoo here in Michigan, and the lower, what would you call that, southwest area. And one of our providers, which is the Bronson organization, was already working with Meyer, which is a large, think of it as a regional Walmart. Meyer is our one-stop shopping grocery and general goods store here in Michigan, but throughout the Midwest. And Bronson was already doing real retail clinics with them. In addition, obviously, Silicon Valley was looking at this area as an opportunity for growth for them. It was a market that they were not in, and they were very interested in getting there. So we thought we, as a plan, should be presenting something that we thought was viable and reasonable to our members, but also only as a temporary move until our providers could move into this area. When we talk to our doctors, which we do on a regular basis because we have forums east and west side of the state where we bring in the medical directors from our communities and we say, what do you think of a telemedicine service? They were not exactly enthusiastic about it, but when we asked them what percentage of the services you currently deliver inside your walls probably could be done virtually, they said probably 80% is what we see any given day we could do in another way. We could do virtually. And we said we agree, and we think that this is an opportunity. This is a way to shift capacity so that you can do the chronic care management. And if you want to do this service, we will pay you. That was never in question. In fact, we started sponsoring telemedicine services and paying for them here in Michigan as a plan when we were promoting patient-centered medical home, which was 2008. So we ended up doing the RFPs in April. We did the RFPs in February. We did the demos in April for 5, and we very much fast-tracked this, and we launched in October to 2 of our 3 product lines. We launched to Medicaid, and we're paying for that because in the Medicaid world, this is not a reimbursable service, but we as a plan understand that that's a population that has access issues to begin with, and we wanted to sponsor that cost. So we paid for Medicaid, commercial pays for itself, and Medicare we had to leave off the table until we could get the supplemental benefit approved, which we did in January. So effective January 2014, that launched. When we brought this to market, it was a soft launch. We had no intention of advertising this in a broad capacity because this was new. And we really wanted to make sure that the members got a good service, that there were no technical glitches, and that the providers had time to, ask us their questions and feel confident of the service. So we made it very PCMH centric, or PCP centric. The first thing that we did was we said, okay, when the patient contacts you for service, MD Live, we want to make sure that you ask them these three or tell them these three things. The first two are questions, the last one's a statement. The first two questions that we want asked either virtually, online, digitally, or in person with your intake person is we want to make sure that you ask them, do you have a PCP? We're very PCP centric here at Priority Health, and we actually have over 90% of our members either assigned or attributed to a PCP. So we don't want to get in the way of the patients at a medical home, so we make sure that they ask every time, do you have a PCP? Second thing that they ask is, have you contacted your PCP about this concern? Just to make sure that they're reminded that's the direction they should head. If they say yes or they say no, it doesn't, they can still get the service. We don't put a barrier into getting the service, but we do want to make sure that they're reminded about that relationship. The third thing that's said by MD Live is not a question, it's a statement, and we want them to know, the patient to know, that the notes from this visit will in fact be shared back with their primary care. We give that information to MD Live on a weekly basis, and it will be faxed back. It can't be integrated into the medical record because this is an independent service, but it can be scanned into the medical record, and it is shared with the PCP. If the member does not want it shared, we have to respect HIPAA, of course, and they're certainly capable of ending the call at that point. But that the option to not have it shared is not offered. You can see by the rest of the information on the slide that MD Live was founded in 2006. They have 24/7, 365 availability. They are only board certified physicians. We do not use mid-levels in this service, and neither do they. However, our network was offered the option of joining their network, which would be free, or using MD Live as backfill in case they wanted to offer the service themselves. That's out there, that's up to them. And then they use the Schmidt-Thompson medical treatment protocols, and you can go to the MD Live website and look that up if you wish. But this is the service that we decided to use, and when we launched in October of 2013, expanded to Medicare in 2014. And so by the numbers, now here's where we are today. 3,000 plus members have registered, which we do encourage our members to register. We've had a couple of articles in our health journal, which goes out to our membership. And our staff, of course, have been able to access it, have been interested in it. So 3,000 members have registered, and about 902 total 902 visits with MD Live to date. I'll show you what our trend looks like. There's the green line, which is 2014 visits. So you can see they start in January of 2014 with only 8, then 14, then 46, 46, 48, drops again in June, and then starts to trend back up in July in 2014. In 2015, we just see some growth, actually. 2015 so far, we've seen pretty steady growth, and we think that that's the direction it's heading, which is good because we do have sustaining costs for this. The service is paid for on a visit-by-visit basis, but there is a little bit of carrying costs month to month with the vendor. So the benefit really is cost offset, and we're going to talk a little bit about that in a couple slides to come. One of the things that we did ask MD Live to do, and we were sort of a different animal for them. Normally they market themselves to employers. And since Priority Health is pretty innovative, we like a lot of data, so we can do a lot of PDSA. And we wanted to make sure that we were getting a good view of what the services were like so that we could explain to our network what was happening in case they were interested in developing telemedicine services themselves. So we want to know, are the calls coming during practice hours? And this is their definition, 7 a.m. to 7 p.m. And yep, they pretty much are. Monday through Friday, practice hours. We also were concerned about whether it was going to see an uptick in prescription, because urgent care, we see the data tell us that 80% of visits to an urgent care will end up in a prescription. We didn't want to see that happen, and we were very concerned. We wanted to be able to reassure our network that the performance was going to be no worse than and probably better than urgent care or ER. And in fact, that has been true. We also had a lot of conversation with our pediatric practices. They were very concerned about the opportunity or the problem of getting in the way of the relationship with the pediatrician, especially when the pediatricians have so much work to do in those early years. And initially a little bit of activity where we were a little concerned, but we saw that leveled off very quickly. And our predominant traffic has been 55 and older, or 45 and older. So it's mature, working, or traveling adults that have been accessing the service most consistently over time, which we found a little bit surprising. So you can see the satisfaction with the visit, and we don't get overwhelming satisfaction scores. It's not 50% or better that are replying to the satisfaction survey because it's submitted by email. And by the time you have what you need from the visit, you tend to walk away. But the numbers that we get are reliable and enough to tell us that we're doing well with the service. We're pleased. So that's reassuring. And then again, to the cost, where the patients would have gone. Clearly, with a service that's going to be, the option is they got nothing at all, or they got something, and was the something more expensive? There was not that many that would do nothing at all. That's the 8%. That's the other down here at the bottom. They are asked, where would you have gone instead? And other, we assume, is they would not have sought service. So the medium green is their PCP. The lighter green is the emergency. This medium green is the emergency room, and this lighter green is their PCP. So when we look at the possibility, there is 92% probability that this would have cost us more than the $45 that we pay for the virtual visit. Because a PCP visit would have cost us more, and we know that the urgent care and ERs would have cost us more. And we've been doing the math. In terms of the fee alone, we started making money on this particular product right out of the gate. But with the carrying costs, there's more offset to us. And it was never really about that. It was about right-sizing the service and creating capacity for PCPs and answering the market. On the other hand, you'd like to see some return on investment. So over time, we're hoping to get there. We did submit it to our Michigan Association of Health Plans for their Pinnacle Awards as a creative, in the creative category, and they agreed with us. They thought it was a pretty creative response for a health plan to be paying for Medicare and Medicaid virtual visits for their members and to offer a virtual visit product in the first place. So we won that award in 2014. The ultimate goal, though, and the ultimate reason that we're doing this, apart from capacity and market response and access, is we really want to help and show the way for our providers so that they start offering this modality. And obviously, being on a telehealth resource webinar, I'm in the right room. This forum is provided for people interested in doing just that. We do pay for telemedicine. You can find this also on our website. You go out there, you type in PriorityHealth.com. You will go to our website, and then in the upper right-hand search box, simply type in telemedicine, and you will get this listing of codes. None of which should surprise you. They are the 99441 through 444 for telemedicine, which includes both the telephonic and digital. The 99444 right now we recognize as both the email visit and the video visit, because CPT has not caught up with our world here in doing telemedicine services. We're hoping they will soon. That one code accounts for both services, and we pay for both. We also, of course, have other codes that we're looking into and considering, because there's more than just the direct-to-consumer kinds of services. There's remote and hosted, the direct to consumer, the store and forward. There's also the telehealth world, and we're interested in all of those because we think that those can all be of some benefit to our members given the right circumstance and the right service. And I'm assuming, considering the audience and the forum that I've been granted, that we all understand these, the words that we're using here. Remote and hosted, store and forward, direct to consumer. So I won't spend time on that, but I will show you, and I'm sure you're familiar with some of the opportunities that we recognize and we hope that our providers here in Michigan are going to embrace and start offering any day now. Some of which are, and in fact, our parent organization, Spectrum Health, the provider group that is our majority holder, is in fact engaged in many of these already, and we find them very exciting. We were first to market, they followed close after, and have now become a very robust service delivery aspect for telemedicine here in Michigan. Telemonitoring, pretty self-explanatory, diabetes, hypertension, case management. There's lots of opportunity here, and I think probably the barrier that you're thinking of on the phone is, what about payment? Priority Health can and will pay for many of these, but the barrier for the provider always is, but the others don't, and I can't do something different for you. We understand that as a plan. We understand that's a barrier. It's a frustration to us as well. We think this is the right thing to do. But again, being first to market it sometimes means you're lonely. And you as providers have the additional complication of having to wait for the other payers to catch up. Teleeducation, certified diabetes education, lactation, especially you're in the Great North, we're in the Midwest North. We've all had really bad winters recently, and how cool would it be if we didn't have to put people on the road to get services that could be completed well and effectively with remote locations, and make sure that they still got the services they needed. Compassionate programs is one of my favorites. It's the idea that we have service people who are deployed that get to visit or even see their child being born because of telemedicine, or kids who have to be removed from their classrooms for long recuperations from accidents or surgeries, but they recover better, their mood is better, their compliance is better, because they get the social support of still being connected to their classrooms and their peer groups. Tele-ED, obviously, sometimes the specialist that you need is not nearby, but you don't want to put somebody in a helicopter. If you can get the care and consultation you need with a subspecialty or as expert in the field while they stay where they are. In fact, I've seen situations where a subspecialty is in such demand that they basically put them in another country, pay for them to live there so that they can have access to them at night when it's the subspecialist's daytime. Works well for everyone in that case. And that also relates to the kind of opportunity here for translation and services. What about having someone from another country's very limited English specific dialect, but you're connected to someone in Africa or Asia or Polynesia or Malaysia that actually can speak to that person, and for them it's daytime. It's not a barrier. And you've got the translation service you need, and you don't have to have people on staff or on site to do it. Those kinds of opportunities excite me, and I'm hoping that we get there soon. Opportunities for providers, obviously, if you're just primary care, and that's the audience I talk to a lot, I think about the idea that you can see more of the people in person that need to be seen in person. For a lot of these folks that are doing the high acuity, low complexity, high frequency visits, they didn't need to come into the office. It might be an opportunity, it's an income opportunity, but I think that there's better ways to handle that. Also, people that just want to get out of Dodge when the weather gets bad. And this is a way to sort of prime their pump, get them ready in October before they take off, talk them through how this will work, show them the equipment and how it will be scheduled in your office, who they'll talk to, and then wish them a good winter and see them in the spring. You connect with them a couple of times remotely as needed while they're away, and when they come back, there's no interruption to their care, and they weren't going to an urgent care or somebody that you won't ever see the records. And then vacationing patients, I know during April at Michigan, it's always an issue that, you're going to have people going away for spring break. And how nice it is for people to be able to just connect with their physician who knows them already, as opposed to going to an urgent care when they're on vacation. Um, so that's pretty much it. I think this was supposed to be a question slide, so I'll just say that it is and ask if any of you have any questions. Ah, our insured pay. Yep, I need to. Yep, I'm looking at that right now. It says for my insured patients, are they just, and I'm not seeing the rest of the question, unfortunately.
Are they just paying standard co-pay?
Oh, great question. Thank you. Um, yeah, they're paying their PCP copay. The year we launched it, we asked for a specialist level copay. Um, and the second year, we dropped it down to the PCP level copay. And again, for our population, half of which is on a high deductible, they would pay the full $45. They are responsible for, first dollar until deductible is met.
Yeah, I just want to, as you mentioned, you've got a telehealth-oriented audience here, and I'm just really impressed with what you folks are doing to expand care and availability of care by using electronic means. I really think that's just great, and that
Okay.
you understand the value that you can bring to your clients, your customers. That's really appropriate.
Well, we're not your usual health plan. So when I saw the title for today was a payer's perspective. It is one payer's perspective. We know here at Priority Health that when we go talk to a provider organization, that they are unique, and however they're approaching care and service in their network is how they're doing it. And their competitor across the street may be doing it in a totally different way. So we're aware of that, and I just want to make sure that you're also aware that we're different. It's also compelling for us that our service delivery side, our provider entity, has totally embraced telemedicine and is offering all three modalities. They're doing direct to consumer, they're also doing the teleconsults, and they're doing telemonitoring. We have health coaches now that are looking into it as well. So we as a plan are all about this, apparently. And there's a third element that I didn't mention in here that we just completed for our incentive program, which I mentioned earlier for primary care. We embedded a grant process this year for telepsychiatry. It isn't actually for our primary care network. We approached our behavioral health networks and said, would you like to propose something around telepsych? And we had, I think, 8 or 9 responses, 4 of which were finally selected. And Dr. Neufeld, who's going to speak to you next month, is actually consulted with us on the process and helped us review the grants, and is going to consult throughout the year where these projects are being launched. So yeah, we are different. We know that, and we don't think that's discouraging. We think that's promising for other plans and ultimately for the providers, because plans typically are kind of conservative and they don't like to be first to market with anything other than new products that they can sell. We take a slightly different approach, and we try to collaborate more with the providers and think of the member first. And we're hoping that being first to market, the folks that are a little more conservative will simply follow us.
That was very tactfully said about the traditional plan, and I just want to
Well,
see a note from Larry that says, "Can you talk to BCBS?"
can you? Yeah, they are the dominant payer in our market as well. On the other hand, I have to give them props. They have been extremely committed to the patient-centered medical home, and organized systems of care. So they have been extremely, they've driven a lot of the engagement around triple aim and um, developing, transforming the care model here in Michigan. And we just went about it slightly differently, but I think we give each other the nod here in Michigan regarding what we both have been able to accomplish.
You both have lessons learned that you can share with each other, and that will help both of you grow.
We're trying. We're trying.
If anyone else has questions for Mary while we've got her on the line, go ahead and enter them in the Q&A pod. Otherwise, I will just thank you all for joining us, those of you who are still with us. And Mary, I want to thank you especially for presenting. And you'll probably notice that Martha has just put up the survey on your screen. Please fill that out. It's really important to us to know what you think of the webinars we're presenting, and as important, what you want in the future. So, Mary, thank you very much. I don't see any more questions or comments coming in. Thank you for taking the time to share a really interesting program with us.
Well, thank you, Bob. I appreciate the opportunity. Have a wonderful day.